All right, let's talk about the evaluation of the febrile infant who is less than 90 days. So the differential for a febrile infant, as you can imagine, is huge. So just to keep it simple, just consider viral versus bacterial. Viral will be the most common, but bacterial will be the most dangerous unless you're considering herpes. So predisposing conditions for children who may have an increased risk for invasive bacterial infection. If they're less than 28 days, they're ill-appearing. If they have fever over 104, if they're unimmunized, if they're premature, if during their perinatal course they had a surgery, had a recent infection, have congenital or chromosomal or abnormalities, if they're technology dependent, so that means G-tube, trachs, those kind of things. If they had a prolonged premature rupture of membranes, and if the mother was group B strep positive, and then also if there's social barriers to follow-up, so they're not as reliable to bring their child in if the child is ill and then the child gets worse. So when we look at the causes behind this, 58% of these instances are from viruses. Rhinovirus, RSV, influenza, and parainfluenza can be the most common. 10 to 15% though are bacterial. UTI is the most common cause, but they can also have bacteremia, cellulitis, meningitis, and pneumonia, amongst other things. E. coli and group B strep are the most common causes of bacteremia and meningitis. And then other potential causes can be Listeria, Staph aureus, and strep pneumo. What makes the evaluation so difficult is that the clinical manifestations can be very vague and hard to interpret. There's obvious ones like unstable vital signs, hypotension, hyperthermia, so fever, or hypothermia. That's not one we typically think about in older patients. And then tachycardia and tachypnea. Also, if they're lethargic, but they can also be inconsolable as well. You may see increased work of breathing, and for sure delayed perfusion would be concerning. And then if they're also poorly feeding, that may also be a concern. Evaluation. So this, in past years, has been fairly concrete, but now we're seeing more pathways that we can go down and explore, so we'll go over those. Typically for children in the 0 to 28 day range, you will see most physicians right now do a full sepsis evaluation, so that means getting a spinal tap and testing the spinal fluid with a gram stain, protein, glucose, cell count, culture, and then maybe some ancillary studies tacked onto the CSF, such as HSV, enteroviral, and par-echovirus PCRs. Then they get a blood culture and urinalysis with culture. They may also get CBC, LFTs, and a CRP, as well as HSV studies if needed. But now, as more evidence comes to the forefront, the pathway is changing and we have different clinical practice guidelines. I would stress to you to review the clinical practice guidelines in the learning resources section of the inpatient RISE course, which you're currently on, and that will show you all the different treatment modalities for different disease processes. But I thought we could just take a look first at the 7 to 28 day algorithm and then the 29 to 60 day one real quick. Again, this will just be kind of a quick summary, and so you'll want to look at this on your own. And so you can see here that this algorithm corresponds to patients who are 7 to 28 days of age. So if they're outside of this, we can't apply it to them. And remember, this is just a recommendation. It's not a mandatory guideline to follow. And so start off, are they 7 to 28 days of age? Are they well appearing? If they're not, then they get the full sepsis evaluation that we talked about. And if they are, then we start off with kind of a superficial study where we get urine analysis with microscopy, CBC, blood culture, viral testing if needed, and then a CRP. And then we also assess for HSV. If they're found to be high risk factors for HSV, then we go down this path with an LP and then go to antibiotics and acyclovir. However, if they're negative, then we look at these studies here, the results, and apply it to the infection checklist and decide if they're low risk versus high risk. If they're high risk, then we go right to the LP and then the antibiotics as well. We can go further down here and see, but they basically get admitted and start on antibiotics. However, if they're low risk, then we can still decide if we want to do a spinal tap, and then based off of that, then we do antibiotics, or we can choose to observe the patient in the hospital without antibiotics. So there's a couple people that fall over here and do this, but still most of us are doing the spinal tap and going forward. And so that is your 0 to 28 days. When you look at the 29 to 60, we have a lot more leeway. And so this shows other causes of fever. So when we think about other causes, we think about bronchiolitis as well. So if they have bronchiolitis, then we can go down this pathway. And if they're RSV positive, yes, you can see this teases out bronchiolitis and UTIs. And then if they're not well appearing, then obviously we do the full sepsis workup. If they are well appearing, we go down here and we do our ancillary studies. We go through HSV stuff. If they're positive, we go over and do the workup and treatment there. If they're still at low risk, based off of the results of the study of the workup here, then we continue forward, and then we can decide on antibiotics. We have the potential, if they don't need antibiotics and they're low risk, that they could possibly be discharged, or we can obtain the spinal tap, decide on antibiotics, and go from there. So again, this was very quick. So just take the time to review it and ask your team further about this. But the main point is just to show you how the treatments vary, and how the workup varies now. And this is all trying as much as possible to be an evidence-based approach. So when we look at treatment, it's a little more straightforward. So 0 to 28 days, we're going to do ampicillin and cefotaxime or gentamicin, and then possibly acyclovir if we're concerned about HSV. And then we'll add vancomycin if they're septic. So 0 to 28 days, we're worried basically about the vaginal flora. So group B strep, listeria, E. coli are the main ones that we're caring about, and then HSV. Then 29 to 60 days, we're looking more at ampicillin and ceftriaxone and possibly vanc if we're concerned about resistance. And then again, acyclovir if we're worried about HSV or not. And then 61 to 90, ceftriaxone and vancomycin are usually the mainstays. The reason is because we're not concerned as much about group B strep, which is covered by ampicillin, and then listeria as well. So if you have any questions, ask your team. And then if you look at the meningitis talk, that will kind of go into more of the pathology and the bacteria as well.